So moving on, our next speaker is John. Dr. Reis retired from office practice of internal medicine in 2009. We're envious already. After nearly 34 years of private practice. He's been active in the field of addictionology for 26 years. He was the medical director of the ADAPT, Adolescent Drug Treatment Center, and for the last 23 years has been the medical director of the ACT Rehab Center at Ogden Regional Medical Center. Dr. Reis has pioneered some methods used to detoxify patients on higher doses of methadone and has helped many pregnant opiate addicts carry out safer pregnancies and avoid difficulty withdrawal syndromes in their babies. He enjoys teaching medical and nursing students, patients, and their families about addiction. 2 years ago, he was part of our program. We've asked him back. And take it away, John. Really appreciate you being here. Yeah, I think so. Just he's got the control thing here.
Just hit the green.
Yeah, I think just
good. Thank you, Bob. We've all honored Harry today. Now I'd like to tell the story about Harry. You probably knew this was coming. Harry and I came to town in the late 70s. He became a few years after I did, and my wife at the time was the medical staff coordinator. And Harry has always enjoyed sartorial excellence, as you've noticed him through the years. Everything is just perfect and right in place. And he came to a Department of Medicine meeting at Ogden Regional, and my wife was checking people in at the door, and she looked at Harry as he came in and said, "Well, Harry, that's a nice new coat you've got." And Harry said, "Well, thank you for noticing." He said, "Well, it wasn't hard. You still have the price tags on the sleeve." So, at any rate, you've come a long ways from that time, Harry. I'd like to have a little bit of a show of hands as to how many here have even heard the word either Suboxone or Buprenorphine. Can you raise your hand? So there's a good majority, but there's still a lot of people that haven't. And I hope by the time we're done, you'll be a little bit more familiar with it. I would guess that there are probably less than 20 people in this room that actually have licenses that allow you to write prescriptions for Suboxone. It's not a hard license to get. It takes about 8 hours of online time, and you can get a license to prescribe it. But you really have to have some kind of an interest for it. So you might wonder, well, why would we have this kind of a topic at this kind of a meeting? And I have to say that I just have come from a meeting that the Utah Medical Association has put together a subcommittee to help advise the legislature on some pending legislation that's going to come down the line. And I have to say that about 2 years ago I gave a talk on prescription drug abuse and methadone and how a lot of our young people were dying from some of these complications. Well, this year, I say this year, 2009, the statistics are that 310 pretty young people died of accidental overdoses from opiates in this state. Per capita, we were pretty close to leading the nation in number of deaths. And the thing that I would alert you to is that there are now multiple members of the state senate and legislature who have had either immediate family members or indirect family members who have died from these type of complications. There's an intense amount of interest in this. There's some really weird things that are being tossed about. One of the thoughts from one state senator is that he would like to propose a bill that every physician who writes a prescription for a drug that either is or could become addicting is then liable personally for the consequences of that drug if the patient has a problem. I don't think that type of law is necessarily going to pass, but this is kind of what we're up against. What I'm going to be talking about today is a drug that can be used and is used for helping to get people off of narcotics, and I think that's why I'm here. Having worked with some of the legislatures reminds me of the old riddle, why is a politician like a baby's diaper? Well, it's because they both should be changed frequently and for the same reason. Think about that. Okay. All right. Well, my potential conflicts of interest, I'm the medical director of a drug and alcohol rehab and a hospice thing. I have lost a lot of money investing in drug companies and health insurance companies, so I'm probably like you, and I don't have any direct interest in the drugs I'm going to be talking about today. These are some of the objectives, and we'll just kind of go through these as we get going. I want to say that buprenorphine really has truly revolutionized the treatment of opiate-addicted patients, particularly those that are in withdrawal and also for maintenance as well. Now, I won't say that this is as startling a discovery as penicillin was to infectious disease, but it's pretty darn close for those of us that are in the addiction field. Very briefly, buprenorphine was a drug that was discovered while they were looking for a better opiate. Now, the main receptor in the brain, and this is as close to physiology as I'm going to try to get with you, but the main receptor in the brain is the mu-opioid receptor. All the drugs that we're used to using for pain relief, like morphine, heroin, methadone, OxyContin, Dilaudid, all of those drugs stimulate the mu-opioid receptor. So drug companies are investigating as to which drugs will stimulate these. Then you might have a drug that's an effective narcotic or pain reliever. And what they found with buprenorphine was that it did stimulate that receptor, but it did not stimulate it very strongly. But in fact, they could use that property to make it a drug that would be a good drug in helping people detox from medications. If you have someone who's in withdrawal, who's on a chronic narcotic user who's in withdrawal, the reason he's in withdrawal, he's opened up some of these mu-opioid receptors. They're empty and they're saying, I want some more drug, and they're starting to feel uncomfortable. So if you can give a drug that at least weakly, mildly stimulates those receptors, but without totally satisfying and without giving them the high, the euphoria, you have a drug that has a lot of potential for being used in patients that are in withdrawal. They found that initially taking the drug by mouth wasn't very effective. It was not absorbed very well from the stomach. So they initially used it parenterally, had about a 6-hour half-life, a very potent medication when used that way. But some bright people figured out if you gave it sublingually and absorbed it through the mucous membranes of the mouth, you had actually pretty good absorption. So this is kind of the background of where that drug came from. It was primarily studied in England and France. Now, to reinforce why this is a good drug, I mentioned it's a weak mu-opioid receptor. It's not a strong one, so people aren't out there seeking this drug because they want to get high with it. I would have to say there are a few people who, in fact, like to use larger amounts of it. Nothing like you would see with patients using heroin or other drugs, but it's really pretty rare in the addicted community to be using this drug because it's going to make you high. What we find is there is some diversion of this drug out there, and it's kind of interesting. What happens is someone has a friend who has some of this, the trade name is Suboxone out there in the community, and they're starting to have a little withdrawal, or they've run out of money and they can't afford their drugs from their drug dealer. And so they will seek out someone who can sell them or give them an 8-milligram pill. And they will use maybe half a pill once or twice a day, or a whole pill. And for most of them, that will keep them out of withdrawal for a day or two, just that one dose. We end up using more elaborate withdrawal schemes using this drug. And I suspect sometimes we're probably using maybe more than we need to get our patients through the withdrawal process. But at any rate, that's how it's being diverted out in the community, and I think that speaks pretty well for it. The second reason this drug works well is when you have that mu-opioid receptor, it has an incredibly strong affinity for it. Now that affinity, that stickiness to it, is so strong that there's already a narcotic there, like methadone or like OxyContin or heroin. If you give that to someone who's kind of loaded all their receptors with this other drug, you will flush the narcotic off of there, and you will replace it with the buprenorphine. Well, the buprenorphine has about 40% of the activity at stimulating that receptor as, say, the heroin did or the methadone did. So what happens is you get an immediate drop-off on how much stimulation you have to that receptor, even though it's filled. So that patient, if he has a lot of this regular drug knocked off by buprenorphine, will go into fairly intense withdrawal. And the patients out there know this. When they bought this Suboxone off the street from their friend, and their friend didn't warn them about it, and they still were a little bit high, and they took it, they said, I've never been so sick in my life. I can't take that drug. That drug just makes me feel horribly. So that's a very strong property of the drug that we find useful. The other thing, if you're using the drug in maintenance and you have your mu opioid receptors covered by the buprenorphine, and they take a shot of heroin, they will get maybe some analgesic effect, they'll get some sedation, they'll get some respiratory depression perhaps, but they won't get the high that they would have had if they had just taken the heroin without having those receptors covered. It has another property that's kind of interesting. It blocks one of the other opioid receptors in the brain called the kappa receptor. And we never talked about kappa receptors in my family, and we didn't talk about it in medical school either. And the kappa receptors are kind of interesting. There's probably the main drug right now that we're familiar with is tramadol or Ultram. That's the kappa receptor. It weakly stimulates the mu opioid receptor, but the main thing, it stimulates the kappa receptor. And this is why some drug companies will come to you and say, well, this drug isn't really very addicting because it doesn't stimulate the mu opioid receptor. Well, baloney. You know, we see people abusing Ultram. We treat probably once a month or so an Ultram addict. And the only difficulty with the kappa receptor opioids is they give you a pretty tough detox when you're facing those kind of patients. Now, we had some old standbys, and this is something I want you to take home because this is what you can do. You don't necessarily have to give someone buprenorphine to help someone who's withdrawing. For years, we've used clonidine or catapress. You can put on a catapress patch. You can give them the tablets. This will, in fact, slow down the withdrawal symptoms. We gave some very, very good detoxes using clonidine years ago. And in fact, I can remember telling people, I'm really proud of the type of detoxes we're able to do using clonidine. The only problem, the way we did it in the hospital on our detox unit, is we gave enough of it that it really drops the bottom out of their blood pressure. And we'd have them wearing support stockings and going around with systolic blood pressures in the low 80s, but they would be pretty comfortable with this. Well, as an outpatient, if you have someone that's trying to get into a detox unit or has an appointment with a detox doctor and they're miserable and you don't want to just give them more narcotic, you can give them some clonidine. They do this in the emergency rooms all the time. They'll give a patient some clonidine until they have their appointment with our counselors the next day or things like that. We can always use NSAIDs for the muscle aches because withdrawal is just like having the worst case of flu that you can imagine. You just ache all over. Every muscle aches, every bone aches, your teeth ache, your jaw aches, you have diarrhea, you have nausea, you're sweaty, you're cold, you're clammy. It's a pretty uncomfortable situation. And so the NSAIDs will give quite a bit of relief for that. The beta blockers are incredibly useful because the main symptoms of withdrawal are because you're pouring out tremendous amounts of adrenaline. And in the process, if you can kind of moderate that a little bit, their palpitations, their heart racing, their jitteriness, that internal shakiness improves quite a bit. And then other drugs for other symptoms. Occasionally, sometimes we will use some Librium or lorazepam to help them with their anxiety associated with withdrawal. There are several forms of the drug available. There's an injectable form, which is Buprenex. It's not used on our detox unit very much. Sometimes it's used in the hospital, but around here I don't think we use that very much. The pure buprenorphine by itself has a trade name Subutex. And that's a drug, as I'll talk about a little bit later, that we use primarily in patients who are pregnant so that we don't have to give them a second drug. So why do we have this other drug, this combination of buprenorphine and a narcotic antagonist called Naloxone? That drug has a street name of Suboxone. There are several others that are out there, but in this area, in this community, Suboxone seems to be what people know it by. Well, here's the deal. The injectable form of buprenorphine was found actually to be an incredible drug that drug addicts loved. So if they could inject the drug, in fact, everything I said about being a weak stimulant, it was at least enough of a stimulant. They really liked it parenterally. And, you know, we have addicts out there that are taking virtually every drug known to mankind, crushing them up, trying to dissolve them some way, and then shooting them up. They do that with OxyContins all the time. They do it with a lot of other narcotics. Well, if we're going to give someone a sublingual drug, which dissolves very quickly and very completely, and you know, for an addict, that's wonderful. You can then inject that quite easily. But what the FDA decided to do is say, well, let's make you combine that with a narcotic antagonist. When you take this Suboxone by mouth or even sublingually, the naloxone is inactivated as it passes through the liver, so nothing happens. You don't trigger withdrawal. But if you dissolve that tablet in solution and then inject it, you will throw that patient into immediate and horrendous acute withdrawal, just like giving Narcan in the emergency room. It's that good. So it has helped reduce some of the diversion. Now, there are a number of protocols to try to help people get off of their narcotics using Suboxone. And I'm not going to say one is necessarily the right way to do, because I'm going to discuss the way that I like to do it, which is really more of a short type of program. I felt a little bit better about the program we use at our ACT unit when I went to a conference, the California Society of Addiction Medicine, just in October, and Mark Fishman from Johns Hopkins showed us what his protocol was. He would take a patient on the first day. Of course, you have to be in withdrawal before you start it, and he would divide the 8 milligrams into divided doses, and that would be their first days. The second day, he would give divided doses up to 12 milligrams. Day 3 and 4, he would consider that a stabilization dose, and he would give them 12 milligrams. Then he would start tapering it. So by day 7, you're down to nothing. Or actually, day 8, you're down to nothing. The protocol that we use at ACT is similar to that, but it's sort of tailor-made to the patient. And I've drawn what I have tended to do when I do some outpatient detoxes, and I don't know exactly how much they're going to need. I usually take them all the way up to about 16 milligrams a day. However, in our detox unit, we have some patients, particularly interesting enough, the young people on OxyContins, they don't seem to need quite as much buprenorphine as, say, the heroin addicts or certainly the methadone addicts. So we may not go quite as high as 16, but let's imagine that we do. Day 1, we give a little bit smaller than 16 milligrams, somewhere between 8 and 12 milligrams. Day 2, give them that whatever they got on day 1 plus another 4 milligrams up to about 16. And then I cut it down by 2 milligrams a day till they're gone. So in our facility, if they're in the hospital those first 3 days, which is 2 nights and 3 days, they're in the hospital, and they go home. The prescription I start them on is 14 milligrams a day, and it usually takes maybe 5 pills because we cut 8 milligram pills into halves and quarters. It's not a very expensive way to detox patients, and in a week or so or less, they're actually totally detoxed. And really, the addicts who have gone through detox and experienced just withdrawal on their own, or they've gone to jail and they went through detox, they know the clear-cut difference between being on a drug like this and detoxing on your own. It's an incredible benefit. So one of the biggest mistakes I've already alluded to that someone can make in using a drug like this is you give it too soon. You give it when someone is not in withdrawal. And think about it, if someone's in withdrawal, they're clearly having some open receptors for the buprenorphine. And we don't give them a big, massive dose to begin with, just little doses. And they won't have their withdrawal intensified by starting this drug. But if we give it way too soon, they're going to get into some real trouble. And if you start triggering their withdrawal because you've given the Suboxone a little bit too early, you've got a horrible withdrawal for at least that first day or two, because it's hard to ever get them back into balance on that first day. If you just wait long enough, you're going to be okay. There's all kinds of scales we can use to have the nurses determine, okay, there's enough symptoms for them to start this drug. Now, you have to be aware of some potential interactions with this drug and how you might get into some trouble. I mentioned some of the early studies were done in England and France, and those studies used the parenteral form of the drug, and they found that when they were also using Librium, they actually had some deaths using the drug. And this was somewhat scary, somewhat shocking. It turns out that Suboxone or buprenorphine is a drug that is totally different from every other narcotic you've used. If you look at a graph and you plot the respiratory depression this way and the dose this way, it's just a linear reaction. Some are a little sharper than others, but the more drug you give, the more likely you're going to get respiratory depression. With Suboxone, you peak at about 32 milligrams and you give more and more dose and you don't get any more respiratory depression. So it's a drug that by itself is almost impossible to cause yourself to stop breathing or to be in trouble with it. The only problem is if you took a narcotic on top of that, or some phenobarbital or some Librium or Ativan, that has some additive effects, some depressant effects. So you have to be a little bit careful with that. And I will say particularly in a term I'm going to use very loosely, and that's the elderly patient. And I can't believe I'm saying this, but the elderly patient might be a woman in her late 50s. Oh, God, how did I say that? But at any rate, if they have some COPD or any other concurrent medical illnesses, you can get into trouble. I had one patient, I will never forget, who had came in. I'd seen her, and we started her on a protocol. And at 6 o'clock at night, she got, I think she got 50 milligrams of Librium. No, 25 milligrams, excuse me, 25 milligrams of Librium. And because she was also coming off of very high doses of Xanax, at bedtime I gave her 60 milligrams of phenobarb to reduce the likelihood of her having withdrawal seizures. And she got, by our protocol, about 4 milligrams of buprenorphine at around 11 o'clock, and then she had nothing else. That's all she had. She's 58 years old. Well, I get a frantic call at 6:30 in the morning. She's got gurgling respirations. Her oxygen saturation is 65. We've called the rapid response team. Oh, thank God for them. They're wonderful if you have them in your hospitals. And we ended up transferring her upstairs. Obviously, did not have to be intubated. Fortunately, had aspirated but did not get a pneumonia from it. And actually, about 3 days later, left the hospital, and 2 days later, then came back into our program for treatment. So it had a happy ending, but just that combination was something that got her into trouble, and it triggered. She was a TRICARE patient, and I want to tell you that the people that are out there managing TRICARE sent me a nasty letter about how I was overdosing my patients and all that. So I had to justify what I was doing. So it is something to be concerned about, I would say, particularly the addition of phenobarbital to that mixture as well. Now, we have a couple situations that I would call special situations. And I want to go back a little bit to when I first took those courses that you take to get qualified to get your buprenorphine license. And the course I took was actually at the American Society of Addiction Medicine. And the handouts and everything else, all it did was it talked about how do you transition a patient in your office from heroin or any other narcotic over to Suboxone over a period of several days. It didn't say anything about how do you withdraw someone from any of these drugs. So the use of these drugs in withdrawal is something that people figured out. This is something that will work. We've got to figure out our own schedules and how to do it. But the situation with methadone is a very unique one. Methadone has a pretty intense binding to those mu opioid receptors. And methadone withdrawal is unlike something any of you have probably ever seen. Now, if I get a typical heroin addict coming in, they're around 12 hours are getting a little restless and fidgety, and within 24 hours they're probably for sure having some withdrawal symptoms that are improving slowly, and by day 3 they're very minimal. Day 5 they feel pretty normal. That's a typical heroin type withdrawal. People don't die from that. Sometimes they wish they were dying. They feel horrible. Because they're not going to die from it, about half the insurances in this country will not pay for inpatient opiate detox. That's just a little aside. Now, methadone is a different type of withdrawal. You don't start seeing the withdrawal for at least 48 hours and more likely 3 or even 4 days after their last dose. And it's a pretty awful, typical opiate type of withdrawal. And that withdrawal goes on and on and on, and by day 26, they are still as uncomfortable as they were on day 7 or 8. This is why most people don't get off methadone all on their own. It's a very tough drug to get off of. So in the initial protocols that were put out in all these teaching sessions for getting your license, they suggested, if you're going to take a patient who's on methadone, they should be on a dose of maybe 30 or 40 milligrams a day, and then you can actually get them into some withdrawal symptoms, and you treat them like any other narcotic patient. And in fact, that does work quite well. Done that a lot. Unfortunately, most of the patients coming to us are not on 30 or 40 milligrams that are taking methadone. If they're in a methadone clinic, you usually have to use a minimum of 80 milligrams a day to keep most patients on the straight and narrow, and very frequently it's up to 120, maybe even 200, some 300, 400. Last time I spoke, several patients on over 700 milligrams a day. Well, that's a very unique situation, and the detox on that would be incredibly tough. I have detoxed some patients from as much as 165 milligrams a day. But that adds several days to their hospitalization, and I would only do it to someone that's in the hospital, and it has to be someone who's incredibly motivated, because no matter what you do, the first day is never perfect, and they're a little bit uncomfortable, and they really need to be motivated. Now, I'd like to spend the last bit of my time talking about using buprenorphine in pregnancy. One thing that's makes fairly good sense is that if you have someone who's pregnant, you want to minimize the number of drugs you're giving them for sure. And so you can get buprenorphine all by itself and don't have to use the Suboxone product, which is a combination in pregnancy. Why would you even think about using any kind of a maintenance narcotic in a pregnant gal? Well, it's because the fact that someone is using narcotics and they're pregnant immediately puts them into a high-risk pregnancy category. High risk because they're high risk of having premature deliveries, low birth weights, miscarriages, a whole variety of complications that occur in these young addicts. If you think about it, if you're a heroin addict, you're not in a constant state of euphoria. You're in a state of either euphoria or worrying that you're going to go into withdrawal, or in withdrawal trying to get your next dose of medication, because you're using short-acting drugs. And so every day you're going into some mini withdrawal at least every day. And each time they go into some withdrawal, that fetus is at risk. And so this is why they're so much at risk to have all these complications. Well, in the past, the gold standard, and you have to remember that, and if you're counseling patients on their pregnancy and what drugs to use, you must tell them, we have a lot of experience using methadone. We've used it since the 70s in pregnancy even. I have a lot of experience with it, and that's what for years people have used. You come in, you're a heroin addict, we'll put you on methadone. We used to be able to send them to the University of Utah, and they had a high-risk pregnancy clinic there, and that's one of the main things they did. I think they got tired of doing that, and they don't do that anymore. So this is up to us in the community to try to help manage them. But there's a problem with the methadone. First off, I mentioned methadone is a tough drug to get off of. So the mother is going to be facing a difficult detox in the postpartum phase. But to me, worse than that is that this brand new baby has done nothing wrong in the world, is suddenly faced with the fact that it's going to be in a very prolonged opiate withdrawal syndrome from coming off the methadone, because he's dependent on methadone when it's born. And it's not unusual to be on liquid morphine, which is a drug they use to manage their withdrawal. On liquid morphine in small doses very frequently throughout the day for at least a month, and more often 2 months or longer. Now, can you imagine sending home a young female opiate addict with several bottles of pure liquid morphine to be given to her baby? I think that's also a bad situation as well. So, I think that's kind of the downside with using the methadone. But initially, there had been almost no experience using this drug, buprenorphine, and I have to say, in looking through the literature, some of the earlier experiences were kind of iffy. Some benefit, some seem to have more problems with it, and you could really not find very many good studies. Well, about 2007, Marjorie Meyer at the University of Vermont came up with a very good study and compared head-to-head methadone treatment and buprenorphine treatment during pregnancy. It had 33 in one group and 32 in the other group. And what she found was, the outcomes were good in both groups. There was not any safety issues raised. And there were statistically significant improvements in how long the baby was carried. The buprenorphine was to 39.2 weeks and the methadone to 38 weeks. So it was about 1 week difference. That was statistically significant. The birth weight was increased in buprenorphine by 300 grams. So that was statistically significant. The neonatal abstinence syndrome, in other words, how often did you have to treat the babies with withdrawal, in the methadone group was somewhere around 70%, and in the buprenorphine group it was around 25%. So there's some additional benefits there. And then the last thing was that the babies had 6.5 days in the NICU with methadone and only 4.5 days with the buprenorphine group. So there were some clear-cut statistical benefits. I'm almost out of time. I will say, if you have a patient who's already on methadone, they become pregnant, you've got to be absolutely crazy if you're either going to try to take them off methadone or you're going to try to switch them to buprenorphine. You just don't do it. You keep them on the methadone. They've set their course. If they're on any other narcotic, you at least, I offer them that option. I've had, in the last month, I've had 3 ladies deliver. One was on 8 milligrams a day of buprenorphine. The second was on 7 milligrams a day. And the third was only on 4 milligrams a day. And the first 2 delivered a couple weeks ago, and they did not have to have any detox on their babies. And the third one just delivered last night. So far, her baby hasn't shown any withdrawal symptoms. But still a little bit early for that. So I feel good about that. I feel that we're giving them a reasonable option. And I think this drug has proven to be very helpful. So, any questions? Why don't you, I guess, go to the microphone.
I have two questions, John. One, we see a lot of patients in the emergency room that are on Suboxone for 3-6 months. Is there an indication for that long term?
Well, I mentioned I didn't talk about a longer term withdrawal. I can remember when I first started using this, people would come from a treatment center in Salt Lake City, and they would be taken off their heroin and put on 24 milligrams of Suboxone a day, pretty big dose, and given a month's prescription with instructions, well, come back here in about a month and we'll talk about cutting down. So, I mean, this is something that would take a very long time. When you're on Suboxone for more than just a couple of weeks, it becomes a difficult drug to withdraw from. Not quite as bad as methadone, but it has its own unique properties when you start using it long term. So my feeling is that a protocol that takes much more than a month at the most to get them off of their drugs is probably a little longer than you need.
One other question: that when I practiced surgery, we used to use Buprenorphine in patients who'd had history of narcotic problems. Is that not available to physicians as an IM or IV form without special credentials now? Have they pulled Buprenorphine away from the general?
That's an interesting question. I know for me, in a detox unit, to be able to write prescription for buprenorphine by itself, which could be Buprenorphine also, I had to have that special license. My DEA license starts with X instead of A for that. And I think technically, if your pharmacy was audited, they might need to have it.
Yeah, this was 10, 12 years ago.
Yeah. I think, and these rules kind of came into effect just a little after that. Yes, sir. Harry, where?
Yeah.
Go ahead.
John, I was going to ask you about the usage, chronic usage in outpatient practice. You know, there was an article in, I think, 2008 in JAMA that came out, and the conclusion of those authors was that if you have a young person who has been a heroin addict and they're in that group that's most at risk for really truly risky and cataclysmic kinds of experiences with IV drugs, that the author's conclusion was that a physician should really be in no hurry to get his or her patients off of Suboxone if that patient was a heroin addict. So I would like you to comment on that in view of what has just been discussed here.
Well, it's a good point, and I think it also points out a difference in practices.
Right.
And I have to say, when I detox patients from with buprenorphine, I'm trying to get them off the drug, and I'm also involved with a program. If I see them privately in my office, a doctor in the community wants them to get off of their narcotics, I have to make sure they're not showing addictive behaviors, and they really want to get off, I will help them get off. Or if I think they're doing addictive behaviors, I'll coordinate that with a program. So I don't just take them off, and if they're a true addict, and just send them on their way, because I'm wasting my time. And I think the article there kind of verifies that. And I think in dealing with methadone clinics, which you can also use Suboxone in the methadone clinics, you're talking about long-term maintenance, and you're using that as a substitute for other behaviors. And there's nothing wrong with that. I don't have any problem with that. But I think there's a difference between the article like that and what I'm seeing in my own personal practice, because I'm working with treatment. I'm not working on trying to do maintenance.
Sure. But just a quick aside, if I might. I know that the company is coming out with a strip that a person will put on their tongue that will have a barcode on it. And this is to address the issue of diversion. And so that barcode will allow you to trace back to the patient's original prescription who it was intended for and who it was written by. So I think that may help a little bit with the whole diversion issue. One other thing, I had a patient who was on methadone who we tried to get on Suboxone, John, and I'd like you to speak to this. He had actually been off of his methadone for 72 hours. We had him on 30 milligrams, and he went into horrific withdrawal at something just north of 72 hours. Is there any way really to get away from that with methadone when you're converting?
Yeah, there's a clinical opiate withdrawal score, or COWS score. It's 45 points on it maximum, and the recommendation is that you probably, with someone that's coming off methadone, you ought to be at least at a 15 level before you start instituting it. And invariably, the trouble I've had in coming off of taking patients off of higher doses of methadone is when the patients have insisted, no, I'm really uncomfortable, and I think we started a little bit too soon. The other thing, the caveat I would say, is in our methadone withdrawal protocol, the first dose of buprenorphine is 2 milligrams. Mm-hmm. And if they start seeming to be very uncomfortable with 2 milligrams, we stop. Put them on a lot of clonidine, try to control their symptoms, and make them wait longer till they then show some additional signs of withdrawal. So that might be helpful there. I was just told I'm kind of out of time, so I will stick around. If anyone has some other question, I'll be delighted to talk to you. Thank you very much.
So John will be over here to the side to answer any other questions that people have. We'll start at 10 o'clock in the other room. Let's go out there and attack those exhibitors.